behalf of Canon Medical, I'm delighted to welcome you to this stroke session, where we have 4 exceptional speakers lined up to share with you discoveries and insights from their research and clinical practice. As you join these experts on the stroke patient journey, you will see how Canon Medical technology touches on all aspects of the patient pathway, and that what matters to us most is providing solutions that make a difference to patients. Our multimodality journey on the stroke patient pathway begins by looking at the role ultrasound plays in carotid imaging and its potential use for early detection and risk prediction. We are very fortunate to have Dr. Mahtab Zamani here to bring this topic to life. Dr. Zamani is a neurology resident at Oslo University Hospital, who will share with you her research study on advanced ultrasound methods in assessment of carotid plaque instability with the use of Canon's superb microvascular imaging.
Thank you very much for your kind words. I will be presenting a study, as Erin mentioned. We have published in Stroke in November 2019. The title of this study, which is a collaboration between thoracic surgery department, cardiothoracic surgery department, pathology and neurology department, and Oslo University Hospital, is carotid plaque neovascularization detected with superb microvascular imaging ultrasound without using contrast media. As Dr. Puig mentioned earlier, while some of the ischemic strokes associated with carotid artery stenosis may result from a hypoperfusion due to a significant stenosis of carotid artery, most of them are related to thromboembolism from an unstable atherosclerotic carotid artery plaque. In recent years, it's increasingly clear that the degree of carotid artery stenosis alone is not the best indicator of stroke risk. And this is due to the fact that stroke may occur as a result of a non-stenotic carotid lesion. On the other hand, a significant proportion of patients with significant stenosis remain asymptomatic throughout their entire life. So this is why research in carotid imaging has focused on identifying unstable or vulnerable plaques. Earlier histopathological studies have related certain features to unstable plaques, and those are a thin or ruptured fibrous cap, large lipid-rich necrotic core, increased inflammatory activity, intraplaque neovascularization, and subsequent intraplaque hemorrhage or thrombus. Large lipid-rich necrotic core, increased inflammatory activity, and IPN and IPH contribute to low echogenicity on ultrasound or echolucency on conventional ultrasound. A little bit of a background on arterial wall. Arterial wall, vessel wall, consists of 3 layers. That is adventitia, media, and intima. Adventitial vasa vasorum normally provides oxygen and nutrition to the vessel wall, and arteriosclerosis is a chronic inflammatory disease that starts early in life. And as the vessel wall thickens, hypoxia due to this thickness induces proliferation of this adventitial vasa vasorum microvasculature and extension of them into the full thickness of vessel wall, that is media and intima. And these microvessels, due to deregulation of angiogenic factors and lipid microenvironment, they have immature phenotype, and they are therefore fragile and prone to rupture. They're morphologically defected and therefore highly permeable and leaky. These leaky neovessels are main cause of intraplaque hemorrhage, and intraplaque neovascularization therefore is a strong indicator of future plaque destabilization and rupture. Contrast enhanced ultrasound, which is a safe and semi-invasive method that complements and enhances the standard ultrasound imaging, has shown great promise in visualization of intraplaque neovascularization. but superb microvascular imaging, which is, as Dr. Fu mentioned earlier, is a new method developed to overcome the limitations of Doppler, conventional Doppler. It uses an exclusive algorithm. It's a software on a normal Doppler machine, which successfully removes, by the use of this algorithm, successfully removes the artifact and clutter arising from a nearby structure, and at the same time preserves the microvasculature, as you can see in the lower line picture. Whereas the conventional Doppler imaging, as you can see above, cannot show this microvasculature or low velocity blood flow seen in intraplaque vascularization. So we took and included 31 patients with above 50% carotid artery stenosis, 9 of which were asymptomatic patients, and 22 were scheduled for surgery, that is carotid endarterectomy. And all patients went through neurological examination and a Doppler ultrasound with B mode, color Doppler, and pulsed wave Doppler. And all patients received the contrast-enhanced ultrasound with 2.5 milliliter bolus injection of contrast material and were examined for 6 minutes. Superb microvascular imaging was done on all patients, and everybody went through blood tests. We also, 19 plaques were assessed histologically. 19 of plaques taken out by surgery were assessed histologically. I should mention here that 2 of the plaques did not arrive to us for examination. One of them was very calcified. Despite several decalcification process, it was not possible to analyze it under the microscope, and the other one was did not arrive to us due to logistic problems. And at histology assessment, plaques were assessed under microscope, and areas with inflammation, granulation tissue, fibrosis, and calcification were determined. And this was done by a scoring system used called eyeballing system. It's a semi-quantitative method used in kidney biopsies. We use the modified version. And in each plaque, additionally, in each plaque, we recorded the number and diameter of vessels with the lumen diameter of 0.01 millimeter and greater in each plaque section. Here you can see the characteristic of plaques we had included in this study, where 5 plaques were determined to be 50 to 69% stenosis of internal carotid artery, and 26 plaques did have above 70% internal carotid artery stenosis. With the B mode ultrasound, plaques were divided into 4, the one uniformly hypoechoic, predominantly hypoechoic, and predominantly hyperechoic, and uniformly hyperechoic plaques. And for SMI and contrast-enhanced ultrasound, in SMI we call the enhancement intraplaque microvascular flow, since there is no contrast material involved. And in contrast-enhanced ultrasound, so it's called microbubble enhancement, basically. We used a visual grading system, a semi-quantitative system, starting at 0 to 4, where 0 was no intraplaque microvascular flow signals were seen, or if they were seen, they were confined to the adjacent adventitia. And further on, grade 1 was when moving intraplaque microvascular flow signals were confined to the adventitia side. Note that they were moving, not stationary, and grade 2 were when moving intraplaque microvascular flow signals were seen at the plaque shoulder, and grade 3 was when intraplaque microvascular flow signals were moving to the plaque core, and grade 4 was extensive intraplaque microvascular flow signals. And the same grading system was used for contrast enhancement on contrast enhanced ultrasound. We analyzed SMI and contrast-enhanced ultrasound visually with the grading system I just mentioned. And I should also mention that contrast-enhanced ultrasound comes with a quantitative inbuilt software. This software plots time intensity curve that gives us peak intensity, which is a value, a maximal intensity in a given time in a given region of interest. We painted around the plaque, entire plaque, and included the entire plaque as a region of interest. And we placed a circular region of interest in lumen, arterial lumen. And we then plotted time intensity curve and obtained peak intensity of the plaque in comparison to of that in lumen. SMI does not come with any quantitative software. It is basically visually assessed. Therefore to have a quantitative measure of the analysis, we looked at a 2-minute video in each patient taken by SMI, and we counted a number of neovessels observed in these 2-minute videos, and that was called SMI count. The goals of this study was to see if intraplaque neovascularization can be identified with SMI, and to compare SMI findings and contrast-enhanced ultrasound using histology as gold standard. We found that with the increasing degree of intraplaque microvascular flow signal on SMI, the degree of enhancement on contrast-enhanced ultrasound also increased. That is the degree on a visual assessment or semi-quantitative assessment, and that was grade 3. And increasing rate of intraplaque microvascular flow signal on SMI was significantly correlated to the increasing number of neovessels at histology, and as well as large areas of inflammation and granulation tissue. Also, we found that SMI count and peak intensity, the two quantitative measurements of the two modality, were significantly correlated. We also found that hypoechoic plaques with low echogenicity had a higher grade of intraplaque microvascular flow signal on SMI, and contrast enhancement on contrast-enhanced ultrasound, and also higher value of peak intensity on quantitative contrast-enhanced ultrasound. And this, I should also mention, the first primary and secondary finding we had suggests that SMI can accurately detect and analyze intraplaque neovascularization with the accuracy comparable to contrast-enhanced ultrasound. And the fact that hypoechoic plaques have been associated with the increased risk of plaque rupture and future stroke, and the fact that our finding shows that intraplaque microvascular flow was detected on SMI and contrast-enhanced ultrasound, and it was related to hypoechoic plaques at conventional ultrasound, should prompt physicians to investigate for further intraplaque neovascularization when presented with the hypoechoic plaque on the conventional ultrasound. Here is a picture taken from our publication, you're looking at contrast-enhanced ultrasound on the picture A, which is to your left, and SMI, superb microvascular imaging, which is the middle picture, and histological slide. This is an above 70% prominently hypoechoic plaque on the near wall of left internal carotid artery in a symptomatic patient. In the picture A, contrast enhanced ultrasound, the influx of contrast material is in yellow, as you can see, and the arrow is pointing at contrast material enhancement, the plaque moving towards the plaque core grade 3. And in the middle picture, picture B, you're looking at the SMI picture, where in SMI blood is colored in white and the plaque is colored black. And the green box is the region of interest, where it's placed carefully to include the entire plaque. And again, the arrow points at the neovessel moving toward the plaque core. And picture C, which is a histological slide, is the arrow is pointing at the neovessel. You can see that by observing the endothelial cells. This is how we observe these neovessels under the microscope. We identify endothelial cells, and we directly therefore identified plaque microvessels, and counted the number of them and also the diameter of them for each plaque. Here is a video I'm going to show you where there is a twin view side by side. To the left is a B mode ultrasound, and to the right is the SMI ultrasound. Again, the green box is the region of interest, and in the left picture, which is B mode ultrasound, the plaque is white, and in the right picture, which is SMI, the plaque is colored black, and the blood is painted white. So you can clearly in this video see the presence of intraplaque neovascularization coming from vessel wall towards the plaque core. And the next video is showing to the left is a contrast enhanced ultrasound, and to the right is a B mode ultrasound. Again, side by side twin view, where to the left the plaque is black and the yellow is influx of contrast material, and by the B mode ultrasound to the right you can see the plaque is not so well visible. And here the cursor is also moving simultaneously in two pictures, and it's indicating the contrast enhanced ultrasound, contrast enhanced enhancement within the plaque. I will show you in a still picture, zoomed in still picture of the same video, where the arrows point at the contrast micro bubbles in plaque shoulder. That is a grade 2 enhancement. Thank you for your attention.
Thank you for that, Dr. Zamani. It's really exciting to hear about the promise of SMI as a non-invasive alternative for assessment of carotid plaque stability. Now we turn our attention to the challenges of acute diagnostics. CT perfusion has been key to the advances of stroke treatment in recent years. So I'm delighted to introduce our next speaker, Dr. Anton Meijer from Radboud University Medical Center in Nijmegen in the Netherlands. He will share with you the state-of-the-art in CT perfusion imaging and its application in acute ischemic stroke.
My name is Anton Meijer. I am a neuroradiologist at the Radboud University Medical Center in Nijmegen, the Netherlands. And I have to disclose that at our department we use Canon CT scanners for performing acute stroke imaging. Brain CT perfusion is used for the detection of a brain perfusion deficit in the brain, which can confirm the clinical diagnosis, the clinical suspicion of an acute ischemic stroke. But it can also identify a stroke mimicker, a patient suffering from a seizure or an underlying vascular malformation. Brain CT perfusion can also aid in the detection of intracranial vessel occlusions, which can be relevant for the treatment of the patient. And CT perfusion is mandatory in the selection of patients in the extended window. Based on the volumes of the penumbra and infarct areas, patients can be selected for intravenous thrombolysis or mechanical thrombectomy. And in general, CT perfusion is a useful add-on tool which makes life easier in the diagnostic workup of ischemic stroke. This is illustrated by this patient. This was a patient presenting with acute onset of aphasia. On non-contrast CT, hardly any abnormalities are seen, but on CT perfusion, a perfusion deficit is easily recognized in the middle cerebral artery territory on the left side. And when you identify such a brain perfusion deficit, it is advised to go back to the CT angiography, because small vessel occlusions can be detected, which could be overlooked in the initial evaluation of the CT angiography. So it can aid in the detection of intracranial vessel occlusions. This is a patient coming in with acute neurologic deficit on the right side, and on brain CT perfusion, an asymmetry is seen in the left cerebral hemisphere. But this pattern of the CT perfusion is atypical of acute ischemic stroke, because there is a pattern of hyperemia with an increase in the cerebral blood flow and an increase in the cerebral blood volume. And when looking at the 4D CTA rendering of the CT perfusion acquisition, an abnormal early enhancing cortical vein is easily seen. And this was a patient who had an arteriovenous fistula presenting as a stroke mimicker. CT perfusion can be of aid in the diagnostic workup, but of course do not forget the importance of the non-contrast CT, because early ischemia, but also intracranial vessel occlusions can be detected on the brain, on the non-contrast brain CT. Brain CT perfusion is a dynamic acquisition over time, where the passage of a contrast bolus through the vessels and through the brain parenchyma is evaluated. The quality of the acquisition, the dynamic acquisition, depends on the patient. The patient, of course, has to lie still for the time during the acquisition, but it is also dependent on the cardiac output and pathology in the brain. Brain CT perfusion acquisition is also dependent on the experience of the technician, but overall it is not a difficult procedure to perform. It is advised to at least perform an acquisition of 70 seconds. In the first phase of the acquisition, the temporal resolution should be higher than in the second half of the acquisition. And depending on the CT scanner you have at your department available, the coverage can be the whole brain or limited coverage. Based on the dynamic acquisition, the time density curves of the vessels and the brain parenchyma are calculated. The upslope of the curve represents the cerebral blood flow. The time of the passage of the bolus, contrast bolus, represents the mean transit time. The area under the curve represents the cerebral blood volume, and the peak of the curve represents the time to peak. And when evaluating the quality of the CT perfusion acquisition, it is good to look at the curve of both the artery and the veins. And the artery enhancement is represented in the red line, and the venous enhancement is represented in the blue line. Of course, the arterial phase is earlier than the venous phase, and in general, the density of the veins are higher than the arteries. Based on the dynamic acquisition, the CT perfusion algorithm generates the CT perfusion maps, and nowadays the deconvolution-based methods are default. For example, the singular value decomposition. And based on the CT perfusion algorithms, the column maps are created. In this patient, there is a left side deficit, and it is an easy way to look at the perfusion maps is to first look at the time to peak to identify that there is an asymmetry. Then look at the mean transit time and cerebral blood flow maps. And in order to identify a true perfusion deficit, there should be a correlation between the mean transit time and the cerebral blood flow maps. The cerebral blood volumes are used for the differentiation between the infarct core and the penumbra areas, although some perfusion algorithms perform a thresholding on the cerebral blood flow. And in this case, there is a summary map created with an area of infarct core denoted in red and surrounding a penumbra denoted in yellow, which corresponds well with MR diffusion imaging. So brain CT perfusion is used to identify a brain perfusion deficit and to estimate tissue viability. And this is highly dependent on the collateral status of the patient. But it is also good to realize that perfusion thresholds are time dependent, that perfusion thresholds do not reflect metabolic activity of the brain, and brain perfusion thresholds may differ between parts of the brain. For example, that it is different for white and gray matter. A new perfusion algorithm which is now available is the so-called Bayesian perfusion. Bayesian perfusion is a probabilistic estimation of the perfusion values and is also delay insensitive. Bayesian methods are less sensitive to noise and enhance the diagnostic reliability of ischemic stroke detection. And the Bayesian method can be combined with prior noise suppression of the acquisition. For example, the application of a 4D similarity filter in order to further reduce the noise in the images. This is illustrated by this case. In the upper row, there is the default deconvolution method, the singular value decomposition, and in the lower row, there is the Bayesian CT perfusion. In this case, there is a left side perfusion deficit in the brain, which is more easily identified on the perfusion maps because there is less noise and an improved demarcation of the affected area. Here seen in the cerebral blood flow and the mean transit time maps. And this perfusion deficit correlates well with the MR diffusion imaging. Another case, patient with the left side thalamic perfusion deficit, which is more easily identified on the Bayesian perfusion maps because of a reduction in image noise. And this again corresponds well with the brain diffusion imaging. And in a larger data set at our site, we have indeed demonstrated that the overall image quality of the perfusion maps is judged higher for the Bayesian CT perfusion in comparison to the singular value decomposition. Image noise in the CT perfusion maps can be further reduced when applying deep learning image reconstruction prior to the Bayesian perfusion algorithm. And this is illustrated in this case with superior quality of the image maps. When selecting patients for therapy in extended window, this is done by estimating the volumes of the infarct core and the penumbra areas, as has been demonstrated in the dawn and diffuse studies. In those clinical studies, the rapid software algorithm was the default method of the perfusion processing, but it has been shown that Bayesian CT perfusion is non-inferior for estimating the infarct core and penumbra areas. But it is important to visually inspect the summary maps for errors. For example, in this case, CSF spaces were incorrectly denoted as infarct core areas, as was a small area of tissue loss in the brain. So it is important to identify these errors which can be easily corrected on a workstation. In the last part of the presentation, I will discuss some developments on CT perfusion. One really important development is that CT perfusion is really integrated in the workflow by an automated processing, so a zero-click solution. This saves time and for the diagnosis, but it can also be combined with AI support for the detection of pathology. So the perfusion deficits can be automatically detected and tissue viability estimation is readily presented to the reader. It can also be combined with automated detection of hemorrhage on non-contrast CT, the identification of early ischemia, but also the detection of intracranial vessel occlusions on CTA and the evaluation of the collateral stratus. These developments are taking place now and different packages are available for application in clinical practice. And this integrated workflow aids the radiologist and clinician for making both a fast and accurate diagnosis, which is really important in the diagnosis of acute ischemia. In order to further reduce the radiation dose and save contrast agent, but also to save time, the CT perfusion can be combined with the next CTA acquisition. So this is one acquisition where one time point of the CT perfusion is substituted with a volumetric CTA acquisition of the neck by rapid table movement. Also, and that has been investigated at a group of on our department, is that a virtual non-contrast CT can be reconstructed from the CT perfusion acquisition, which is shown on the left side. Something which is already available is the so-called timing invariant CTA reconstruction from the CT perfusion. This is a superior quality CTA of the brain. And therefore then a separate CTA acquisition is not necessary. Finally, which is something under debate and clinical study now, is that the CT acquisition is combined with the CTA of the heart in order for the detection of an embolic source, but also possibility for screening of concurrent coronary artery disease. This is something where the cost effectiveness still needs to be determined, and it has also been debated whether it should be a non-ECG gated helical acquisition or that a separate prospective ECG gated volumetric acquisition of the heart is necessary. This is a topic of current research at different centers. With that, I would like to summarize and stress that brain CT perfusion makes life easier in the diagnostic workup of stroke because it aids to make both a fast and accurate diagnosis. Brain CT perfusion can be easily integrated in the clinical workflow, and automated processing of both CT perfusion, but also the non-contrast CT and CTA is of added value and will aid to improve the outcome of the patient. And with that, I would like to thank you for your attention.
Thank you to Dr. Meijer for that great talk. Of course, CT is not the only modality with a role to play in stroke diagnostics, which is why this next talk from Dr. Puig is so insightful. Based on his extensive research experience in advanced imaging techniques to develop predictive imaging biomarkers, today he's going to talk to us about the role of diffusion tensor imaging as a biomarker for stroke patients.
So I'm going to talk about a few minutes about the diffusion tensor imaging as a biomarker for stroke patients and try to convince all of you to introduce, if possible. So DTI is, in fact, an important field in a stroke. Look at this graph. We can see that every year we can detect more than 100 publications in PubMed. So it reflects an intense activity of the DTI in the stroke field. So the main keywords that I will try to explain is related about the anisotropy, properties of the white matter tissue, the DTI metrics. We explain some details about the detectography, the role of the corticospinal tract in the motor outcome, this specific anatomical area very important for the motor outcome, that's the posterior rim of internal capsule. We'll try to put some attention in the specific DTI prognostics biomarkers. This is the index of this talk. So the main keyword probably that I starts with anisotropy. What is anisotropy? Probably you know what is anisotropy. The anisotropy is the preference that the water molecules diffuse along to the axons. So the white matter tissue is anisotropic because the main direction of the water molecules are along the axis of the axon. Conversely, the liquid in the ventricles have the anisotropic environment. So thanks to this property of the white matter tracts, we can calculate, thanks to the DTI, we can calculate specific anisotropic indexes to provide information about the brain microstructure. Another issue that probably you are perfectly clear is how we represent in a color map the fractional anisotropy. The main white matter tracts, here the corpus callosum, the corticospinal tract in this axial image of the brain, or this other, this fascicle, the longitudinal superior fascicle, we can see that these kind of white matter tracts represent a different color. The tracts where the fibers run to the left to the right are internationally represented in red. If the fibers go from the upper to the lower, it's represented in blue, and fibers that runs anteriorly to posteriorly are depicted in green. So this is an international convenium, and the brightness is proportional to the degree of the fractional anisotropy. Look at here, the gene of the corpus callosum or splenium, it has a intensity of this high intensity of the color in the same way to the posterior rim of the internal capsule. So what about the detectography? Shortly, we'll see that the three-dimensional way to represent the detectography, the white matter tracts could be the detectography. The detectography represents the main anisotropy properties. It does not represent individually and specifically axons, obviously, but we have a big picture of the fibers in the brain of the patient. So it's perfectly, we can implement perfectly the protocol into the stroke setting. So what are the main published and the main relevant track from clinical point of view? Most probably is the corticospinal tract. This tract regulates the voluntary movements of the extremities, the upper and the lower extremities, and the motor deficit is one of the main problems in the stroke patients. So we can study several tracks, but we mainly will put attention to this projection fiber that is the corticospinal tract. So if you want more information about the correlation between different atlas and DTI images, you can take this nice paper published few years back by Jellison. So you can have all the details about this role. So why we need to include DTI, if possible, in the clinical protocols when we are studying stroke patients? The first one is to improve the diagnosis, to infer about the functional outcome. Now we will see some examples, and try to put a special role as a biomarker for a stroke. So the first application I recommend to put attention is try to analyze, to quantify the anisotropy in the case of to detect and quantify the wide degeneration. We can see this invert in the deep territory of this left MCA before the 12 hours. So the fractional anisotropy in the corticospinal tract when it's crossing the stem, you can see no difference. The ratio is the same. The fractional anisotropy is the same in the left than in the right side. But at day 30, you can see that the fractional anisotropy here in the right, in the contralateral side of the stroke, is higher, and it's decreased. The value is lower in the ipsilateral. So the ratio decrease. This decrease in this ratio is correlated with the stroke severity. Patients with a higher deficit, motor deficit in upper and lower extremities. So using DTI, you can quantify the wall degeneration that correlates with motor deficit at day 30. And this is very important. This is very important to try to, and easy, it's pretty easy, to reconstruct the tractography when you are looking the patient into the machine. You can do this during the examination because it's really easy. Try to reconstruct the corticospinal tract and overlap the diffusion sequence in order to see if there is a lesion load, if the invert interacts is within the corticospinal tract. In this case, you see a large, moderate, large invert, but the corticospinal tract is preserved. This is the opposite case. You can see here a small, just 9 millimeters, a small acute lesion. You can see here, it's very initial, it's very early stroke, but there is a difference. You can see here a slight hyperintensity in this diffusion weighted imaging, but the lesion involves the corticospinal tract. This patient, you can see here before the 12 hours that this patient will have most probably a worse outcome at month or at 3-month follow-up. So the two prognostic biomarkers you can clinically consider for stroke patients is the corticospinal tract lesion load. If the corticospinal tract, I repeat again and again, is inside the lesion or not, and the fractional anisotropy remote to the invert in order to quantify the wall degeneration component. So this is a revision that we published 2 or 3 years back. If you want, you can read in order to better understand these concepts that I try to explain here. So this is another important slide. It's a bit frustrating for radiologists, but when you see a patient, 1 day or 3 days, not just in the hyperacute or acute stage, but over 24 hours or 3 days, it's very important the stroke severity. The motor score of any age is very important because these explain the 30% more or less of variance of the outcome. As a radiologist, using these techniques, we have more or less 30% or 40% to improve this accuracy. The stroke severity is very important. Other issue is in acute stage when you have the penumbra, if the penumbra is reversible or not, because the vessel recanalized or not. This is another kind of issue. But in this scenario, it's more difficult to provide DTI in the protocol, in the imaging protocol, because time is brain, and we don't have this range of time to study the structural connectivity. So the next is not just put attention to DTI. If not, we have to incorporate, if possible, the functional connectivity. In a recent data that we are trying to publish in these weeks, we are seeing that probably the functional connectivity could provide better information and could improve better the motor outcome or the ranking of the patients better than DTI. But if we can merge both technologies, the improvement of the outcome could be better. So this was my speak.
Thanks to Dr. Puig for rounding out a multimodality masterclass on stroke diagnostics. Now it's time to take a step into the angio suite. There is no one better to bring you their experience of interventional neuroradiology than our next and final speaker, Professor Siddiqui. Today, Professor Siddiqui will demonstrate the benefits of having high definition during intervention and how it leads to safer procedures and better outcomes for patients.
Thank you very much. I really appreciate a very warm welcome. And so the charge today is to talk to you a little bit about what we call high-def imaging or high-definition imaging. And so it's relevant to me because neurosurgery started off by surgeons doing operations, including complicated operations with loops. Now, we then migrated to the operating microscope, and you can imagine this is the kind of detail we see under an operating microscope. You can see multiple cases of aneurysms, there's atherosclerosis, the angulation, the detail, the perforators, the branch points. These are all being visualized because of the microscope. So while it's really that effective in open surgery, why would we not do that in endovascular? And so that was the task that we, my mentor, Dr. Nick Hopkins, actually reached out to his partner, and who was a physicist and X-ray specialist and engineer, Dr. Steve Rudin, to say, hey, can we get X-rays to do better than where we are right now? Could it improve device or anatomic visualization, improving safety of procedures? And so he came up. So this is one of those original prototypes. Here it is mounted to an actual C-arm, where you can see this is the original device that he came up with. So this is a microcatheter, and you can see the coil wind within it of the microcatheter, and these are coils being delivered. And he was able to bring this down to 35 micron resolution, where you could actually see the difference between one pipeline inside another pipeline. So that was the kind of resolution you're getting. And so from that original study that we did in humans, the prototype that we have commercially available gives us about 70 micron resolution pixels, which is now available for clinical commercial use. And that's what I want to share with you, is the value of this system is that there's a smooth transition between the standard flat panel detector down to high def with standard FOVs compared to the new high def zooms. And really it's just a touch of a button as you mag up or down to zoom in from one or the other. So this is an example. This is obviously a phantom, but there you can see two braided devices, and under conventional flat panel versus high def, you can see the kind of detail that you get. So this is a standard flat panel detection of lateral fluoro, and this kind of shows you as we go from 12 to 10 to 8 to 6 inches. And that's the end of flat panel, and this is where we go into a 3-inch and then 2.3 inch. And then this is what's currently available, a 1.5 inch. So you can imagine the kind of detail one can arrive where you are seeing the platinum wires, but you're literally even seeing the chromium cobalt in there. And you can see the compression of the device in here and a little bit more maybe relaxing out here and out here. So it really allows you to visualize the device like never before. So the question then became, well, what happens to the radiation dose? That was the first thing. You must be radiating them. So the point is that when you have the integral patient dose based on the KAP value, it's a lot lower because of the much smaller volume which is being irradiated. And so it really is, the best example for this is that it is a high resolution X-ray microscope, just like the one I have in the operating room. And this really can make it quite unique, where you have pixel size compared to a flat panel of 194 down to a 75 micron resolution. That gives you a lot more detail that you would not be able to otherwise garner. And so, and the radiation dose becomes a lot better based on the fact that you're going for a much, much, much smaller area than you would otherwise. So here's some case examples that I like to share with you guys. Here's a 31-year-old with family history of subarachnoid and has a 5-millimeter aneurysm. You can see it's a dissecting aneurysm. She comes in with a new 6-nerve palsy, and there is the standard FOV. You can see these are video clips, not still shots, and this is under high def. So we'll go back and show you this was under standard flat panel detection. And now under high def, you can see that there's, and this is not like a digital zoom. This is truly, even the perforators, the inferolateral trunk complex that you're starting to see is really quite incredible in terms of the detail that you can see. And now you can see that we are up there with the ready to deliver a flow diverter. And this is the flow diverter being deployed. So there you can see it's being pinched. There's the distal capture coil. There's the distal wire. You can see the little connections in here. You can see the central wire going through it. You can see compression, expansion. So this is an actual case where you can see this kind of detail with all those times as the procedure is being done. So this is something that we had never seen before. And then what you can do is you can do cone beam CT to look at opposition, but look at the kind of opposition you get under high def, where you can very nicely see the device is fully opposed in the region proximal. Obviously, it's not in the region of the aneurysm, and it's fully opposed distally as well. So I think that is really quite tremendous. This is, again, standard flat panel detection at the end. Here's another case, 38-year-old, multiple ICA aneurysms. And again, you can see there's an aneurysm farm here. This is standard flat panel detection and has that parataniotomy. And there, this is, by the way, it's being done awake. The patient actually coughed while we were delivering there. You can see the head opening up. But again, this is the device being delivered and the kind of detail you can see with each angle, with each point. You can see what's happening. Is it flat? There's a wire. And again, you're saying, okay, we need to straighten out the energy. There's too much energy here. Let's release it. And then we'll try to straighten it out. There you can see trying to straighten this window out. And this is always a challenge with flow diverters. But okay, how do we open it up? Now you can see we've opened it, but there's a little bit of a waste here. Okay, that is going to be unacceptable. So there is bringing a larger catheter to see if that opens it up. It's still not good enough. So we need to do something else. So you want to make sure you leave. There you go. Now we just release that tension. So let's look at that again. So we are trying to open it up. There's the flex intermediate catheter. There's the micro catheter. And you're pushing the whole device. You're pushing it forward to really get that energy out there. You can see the proximal end is open, and there it just foreshortened. And that's how you confirm that you have good visualization. Again, same thing here. You are making sure that the visualization is excellent in the regions of the aneurysm, particularly proximal. And then you can see the great stasis that is created by the distal carotid aneurysms. And there's the final result as well. So that's the kind of detail that one can get with standard procedures. Here's a 30-year-old, another presented with the worst headache for life, however, no subarachnoid. So this is somebody we brought to the cath lab, and it's got an interesting, quite robust